Thank you for asking me to present on oligometastases. Is it a numbers game? I'm Dr. Stephen David, a radiation oncologist from the Peter MacCallum Cancer Centre in Melbourne, Australia. By way of background, as we know, oligometastasis was a term first coined in 1995 by Hellman and Weisselbaum, and it was coined to describe the existence of a state of limited metastatic burden. This was further clarified over many years, and in 2020, from a radiation oncologist perspective, ESTRO defined oligometastases as 1 to 5 metastases with a controlled primary tumour being optional, but where all metastatic sites must be safely treatable. An attractive consequence of this state is that radical intent metastasis-directed therapy may be considered for selected patients, and researchers have interpreted the principle of oligometastasis in many different ways to inform the design of clinical trials and to manage their patients. More specifically, breast oncologists need to consider the many nuances and differences in breast cancer when managing patients with oligometastases, and it is certainly evolving to be more complex than just a numbers game. I'd just like to start off with brain metastasis as a separate area. In terms of treatment, firstly, radical metastasis-directed therapy, be it surgery, neurosurgery, or stereotactic radiosurgery for brain metastasis, predates extracranial MDT, with a large body of evidence supporting its use. It should be considered separately as it represents a sanctuary site for most systemic therapies that are available. And over recent years, there has been an increasing trend to move away from what was once the backbone of treatment of brain metastasis, i.e. whole brain radiotherapy, and a move towards the more directed MDT of either stereotactic radiosurgery or neurosurgery. And there are now multiple randomized controlled trials that now support the use of stereotactic radiosurgery without whole brain radiotherapy to small volume disease, i.e. 1 to 4 metastases, in patients with good performance status. We know that this provides an equivalent overall survival, less cognitive decline, and this is despite the fact that there is in fact increased intracranial relapse. Now, in terms of the number of metastases that can be treated, originally a lot of the data was in 1 to 3 and 1 to 4, but more. This Japanese study was a non-inferiority trial designed to test larger volume disease, 5 to 10 metastases, whether or not that was non-inferior to 2 to 4 metastases, and certainly there was equivalent overall survival. And importantly, breast cancer was well represented in this basket trial of different histologies, and so certainly we can apply that potentially more than 5 metastases can be safely treated with equivalent outcomes in patients with breast cancer. And even further, moving further along from this, in ASTRO 2020, this randomized control trial compared whole brain radiotherapy to a dose of 30 grain 10 fractions to stereotactic radiosurgery to up to 4 to 15 metastases. The study was stratified by the number of lesions, 4 to 7 versus 8 to 15, but also by histology, breast versus others. And what was demonstrated that between the stereotactic radiosurgery group and the whole brain group, overall survival was equivalent, and importantly, neurocognitive decline was much less at both the 4-month and 6-month mark in patients receiving stereotactic radiosurgery. And so certainly that in terms of brain metastasis, one can certainly consider treating more than just looking at 5 metastases or a small number of metastases, and it can be done safely. Now, moving beyond just the number of metastases, subtype also matters. Now, the Camilla trial, which tested the use of trastuzumab emtansine or TDM1 in patients with HER2 positive metastatic breast cancer and brain metastases, it demonstrated significant intracranial activity. And in fact, in the 126 patients with measurable brain metastases, a greater than 30% reduction in the sum of the largest diameters of target brain lesions was observed. And it was not only observed in the patients that received brain radiotherapy up to 30 days before or after the baseline of enrolment, but also in patients that did not receive brain radiotherapy. And that can be seen in the waterfall plot with the navy blue line showing response in patients receiving TDM1. So beyond just thinking about numbers, one must also consider the role of systemic therapy. Some patients may be effectively managed with that, or in fact in combination with systemic therapy and metastasis-directed therapy. Furthermore, the Her2 Climb trial, which looked at the addition of tucatinib to trastuzumab and capecitabine, also demonstrated intracranial activity. This trial allowed patients to be enrolled with active brain metastases. And what was demonstrated was that in the patients that received tucatinib, the CNS progression-free survival was superior in those patients. And among the 75 patients with active brain metastases and measurable intracranial disease at baseline, the response rate was 47.3% versus 20% in favour of the patients receiving tucatinib. And in a subset of 66 patients who entered the study with active brain disease and elected to defer radiation therapy in favour of systemic therapy, there was still a benefit intracranially, both in terms of progression-free survival, response rate, and also overall survival in favour of patients receiving tucatinib. So again, perhaps combinations of observing asymptomatic small brain metastases and treating some of them and discussing these patients in an MDT with medical oncologists and neurosurgeons is the way forward, where we look beyond just purely the number of brain metastases, but also to the subtype and the role of systemic therapies. Now, in terms of classification, we know about the umbrella word or term oligometastasis, but the EORTC has further codified this classification into 9 separate different oligometastatic states. A group of experts provided this framework and published it in the Lancet in Oncology in 2020. The first column on the left talks about de novo oligometastatic disease, and these are patients either with upfront oligometastases, metachronous, or metachronous oligoprogression whilst on systemic therapy. The second column or group of patients are those with repeat oligometastatic disease that can either be in the form of recurrence after treatment, progression after systemic treatment, or persistent metastases that aren't growing after systemic therapy. And the third group is those with an induced oligometastatic state. So these are patients which initially presented with polymetastatic disease, but were reduced down to an oligometastatic state or few metastases by systemic therapy. And it can be either with progressive, persistent, or metastatic disease. And these different types of this different classification is very useful to think about, and clinicians are now designing clinical trials specifically looking at these different states, as they may result in different outcomes long term. And so certainly thinking about patients beyond just purely the numbers, but also the classification using this framework is very useful. In terms of breast cancer specifically, I've mentioned subtype within the brain, but this certainly matters in general. We know breast cancer is a heterogeneous group of disease. Each subtype has a unique biology as well as a natural history. There's luminal breast cancer being the most common, representing about 70% of patients. HER2 positive and triple negative cancers are less common, but each subtype is managed with a different backbone of systemic therapy with different outcomes. In luminal patients, certainly in Australia, an aromatase inhibitor in combination with a CDK4/6 inhibitor is the standard, with a long progression-free survival of over 2 years in these patients, whereas HER2 positive patients using anti-HER2 directed therapies in combination with chemotherapy provides a long median overall survival of 56 months. But in contrast, triple negative patients where the backbone of care is systemic care is chemotherapy, perhaps plus or minus immunotherapy, so much shorter overall survival and progression-free survival. So one must always consider the subtype and think about integrating the metastasis-directed therapy with systemic therapy whilst considering natural history and obviously thinking beyond just purely the number of lesions. Now, in terms of the evidence that underpins management strategies. The only randomized trial demonstrating a survival benefit is the Sabre Comet trial, which demonstrated a large improvement in both overall survival and progression-free survival in the patients randomized to Sabre treatment of all of their oligometastatic disease when compared with the standard of care systemic therapy. And what's important to note is that within this trial, which was a basket trial of different histologies, breast cancer was well represented, but the number of metastases, although 1 to 5 were eligible, most patients had 1, 2, or 3 metastases within this trial. So using this information to manage patients should certainly be used in the context of what was demonstrated here. Now, in terms of breast-specific trials related to surgery or surgical metastatectomy, most of the evidence is retrospective, firstly focusing on liver metastases. A systematic review of 19 studies demonstrated impressive overall survival, obviously biased by the inclusion and mixed histologies and other systemic treatments that were delivered with a reasonably high post-operative complication rate. And other retrospective series have looked to identify favourable prognostic factors, and these include ER-positive patients, patients that are responding to systemic therapy, an absence of extrahepatic disease, a long disease-free interval, no prior lines of systemic therapy, and excision with clear margins. So when considering thinking about patients that you might offer MDT to, these are the sorts of things clinicians may consider in addition to purely the number of metastases. When we look at a surgical series of lung metastases, again, the evidence is largely retrospective. A series of 90 women with solitary lung metastases from breast cancer identified favourable prognostic features to be, again, a disease-free interval of more than up to 3 years, greater than 3 years, and also the presentation of stage 1 disease at diagnosis. And a separate meta-analysis identified the favourable prognostic factors of tumours less than 3 centimetres, clear margins again, hormone receptor positivity, and single metastases. So again, these are the features that identified retrospectively, but may be useful when thinking about patients that may be amenable to MDT. Now, I'd just like to mention the sternum, as a lot of trials talk about 5 centimetres being the upper limit of normal in terms of Sabre treatment for oligometastases. It's certainly a common site, and it's potentially related to local nodal and hematogenous channel with a more favourable prognosis. Many years ago, Noguchi and colleagues, in fact, surgically resected sternal metastases with sternectomies, obviously a very invasive and toxic procedure, but certainly reported favourable outcomes. But since that time, with the advent of new technology, we've published on single fraction Sabre to large sternal metastases up to, we used doses of 20 grain 1 fraction, and we demonstrated excellent local control at 32 months in 90% of patients with no grade 3 or 4 toxicities, and with very large volumes, with a median PTV of 80, almost 85 cubic centimetres. So size alone is not necessarily something that we look at, and we can certainly, with new technologies, achieve treatment of large deposits, including sternal deposits. Now, in terms of the evidence supporting Sabre specifically in breast cancer, there's very little in the way of prospective trials. Most published trials included patients with less than 5 metastases, acceptable toxicities. These trials have indicated that bone metastases perhaps appear to have superior outcomes. But I'd just like to point to an Italian study published in 2018 of 54 patients, which demonstrated excellent local control, overall survival, and progression-free survival at 2 years. But within this trial of 54 patients, 14 of them had an induced oligometastatic state. So these were patients with polymetastatic disease, which were reduced down to oligometastases. And what was shown was that there was no difference in progression-free survival with the patients that were induced versus those that were de novo oligometastatic. Also, there was no difference between 1 and 2 metastases and bone-only versus visceral metastases. So this provides some interesting hypothesis generating information that perhaps we don't just need to look at the number of metastases at the beginning, but in fact what patients have been reduced to by systemic therapy, and they may do just as well. In terms of trials that are open to recruitment at the moment that have eligibility specific to breast cancer patients, there are quite a number of trials, and I'd just like to point out a few of them. Firstly, the StereoSign trial, which from Gustave Roussy. This trial, interestingly, excludes patients with triple negative disease. So the current crop of trials are looking at more specifics than just oligometastatic disease, but also looking at specific subtypes of breast cancer. This trial looks at only lung and liver oligometastases. So it's looking at specific organs where metastases are located, and again, looking just beyond the number, but trying to look in more granular detail at different clinical scenarios. The NRG trial, BR002, which is a large randomized trial, interestingly has in its endpoints circulating tumour cells and circulating tumour DNA to try and identify these as prognostic biomarkers to help guide clinicians and integrate this information into the management of patients, whereby they might be predictive or prognosticate those patients that might do better with metastasis-directed therapy. And these biomarkers are taken at various time points throughout this clinical trial and may provide important information going forward. The CLEAR trial looks at the specific subtype of ER-positive, HER2-negative breast cancer, and the AVATAR trial, which is now open at Peter Mac, is looking not only at ER-positive disease, but also at oligoprogressive disease. So looking at not only its particular subtype, but also particular classification. And just in more detail, the AVATAR study trial, it's looking at patients with ER-positive disease who are managed with a CDK4/6 and AI, CDK4/6 inhibitor and AI, with the primary endpoint being time to switch in therapy and using the SABR to manage oligoprogressive lesions only. So not all lesions, in fact, are treated, only those that are progressing. And interestingly, this trial also allows repeat cycles of SABR if a patient oligoprogresses at subsequent and later stages after continuing on their CDK4/6 and AI. So again, not looking just at number, but classification as well as subtype. In terms of trials that are open that are not specific to breast cancer, this trial looks specifically for Memorial Sloan Kettering at patients with oligoprogressive lung and breast cancers. So again, classification. And the SABR Comet 10 trial is looking at larger volume of metastatic disease. So moving beyond patients with 1 to 3 metastases, but focusing on patients with larger volume of metastatic disease, 4 to 10 metastases. Now, just this slide on biomarkers. Whilst there is no validated biomarker in clinical use, this is certainly something to keep an eye on. And there are certainly a number of candidates that may be useful to clinicians in terms of integrating with clinico-pathological information. Some of the candidates include ctDNA, which has been demonstrated in lung cancer patients to be lower in measurement in oligometastatic patients compared with polymetastatic patients. MicroRNAs, and specifically MIR200, is a potential biomarker whose expression is potentially able to classify cancers into those that become polymetastatic after metastasis-directed therapy versus those that do not. So you can see how this could be quite useful in identifying those patients who may do well with metastasis-directed therapy. Radiomics is an emerging field in terms of which provides predictive signatures from the conversion of medical images into high throughput quantitative data. And there has been some work done in non-small cell lung cancer using CT scans to identify those patients that might develop and do well and maintain an oligometastatic state in lung cancer. So when I see a patient, what do I think about when I'm reviewing them either in clinic or in a multidisciplinary meeting? Think about how big is the metastasis? What is its subtype? How many are there? And what is the story behind each metastasis? This speaks to classification. What technology is available? What are the capabilities of the linear accelerator? Is there a gamma knife? Is there an advanced neurosurgical team or surgical unit that can resect some of the metastases? What systemic therapy options are there? Biomarkers is something for the future. And where is the metastasis located? Is that site important? Is it the bone? Is it the liver, the brain? And also, always, what available trials are there? Can I enroll a patient on a trial? Which I'm always keen to do. Can the lesion be treated safely? And what is the goal of the metastasis-directed therapy? Is it to eliminate all of the available disease or visible disease, or is it there to eliminate just the disease that is progressing and deepen the response to the line of systemic therapy that may be available to that patient? So these are all the questions I think about. I'd just like to move on to a clinical case to illustrate some of these points. So we managed a 39-year-old lady who was diagnosed in 2017 with de novo metastatic disease. It was HER2 positive and hormone receptor positive, and she was commenced on first-line treatment with anti-HER2 directed therapies, initially with chemo, as well as endocrine therapy and a bone-modifying agent. She also had some palliative radiotherapy to some 3 metastases that were identified. And she then, subsequent to that, needed a double mastectomy due to right-sided oligoprogressive disease within the right breast. But more recently, she had a slight increase in her tumour markers with some posterior rib pain, and a PET scan was performed which showed 7 sites of bone disease that were previously not FDG avid. And so this was an induced oligometastatic state that was probably had a mixture of residual, persistent and progressive disease. And this induced state was due to a combination of systemic therapy, surgery and palliative radiotherapy. We discussed various management strategies with this patient and noted that all of the lesions were small and individually amenable to SABR and not in previously irradiated fields. We discussed options including repeating a PET in 3 months to assess the tempo of disease and also enrolment on SABR Comet 10. Patient wasn't keen as she did not wish to be randomised to the control arm. And after discussion in multiple meetings, we decided to use SABR sequentially in combination with the patient's systemic therapy, which may still have had activity, and use serial FDG PET scans to ensure that the patient was remaining oligometastatic, if you like, and using SABR to treat metastases in groups of 2 and 3 deposits at each time point with repeating PET scans every 2 to 3 months. And what you can see when you look at the forms from the left through to the right is that the patient was reduced from an 7 metastases down to less and less until no metastases were visible. At no point did the patient progress. She remained well with tumour markers falling, and this was done over a period of 10 months. So a cautious approach to make sure the patient wasn't progressing and that the toxicity was acceptable. And in terms of the future, this trial, the ARREST trial, is looking at treating everything with stereotactic radiotherapy. So in fact, looking at patients with polymetastatic disease. And this study aims to evaluate the maximum tolerated dose of SABR in patients with polymetastatic disease. So in fact, using radiotherapy or investigating its use as potential chemotherapy. So moving on from treating patients with just small volume oligometastatic disease. And as we are doing that, technology is improving in parallel with what we're thinking, and this is a PET linear accelerator, which can perform biologically guided radiotherapy. And this technology is able to identify lesions via PET scan and treat those lesions that are hot on PET scan and may assist management of patients with not only small volume disease, but more than just 5 metastases. And this is something certainly to keep an eye on. So in conclusion, oligometastatic disease is a complex paradigm and certainly more than just a numbers game. Clinicians should aim, where possible, to enrol patients in clinical trials or registries and always consider subtype, the role of systemic therapy, the story behind each metastasis and its classification, location, size and safety, its treatability with metastasis-directed therapy, and in the future, biomarkers may play an important role and probably will, and SABR may in fact be able to be used as a systemic therapy going forward. Thanks for your time, and I'm now happy to take any questions.